we need to remember that our patient is suffering in ways that we can't understand. They are suffering in ways that I am blinded to. So to me, what I'm looking for here as I grow as a physician and want to be a true healer is, am I making a complete connection with the person who's suffering? I cannot be a great physician without this humanistic side to my science. Science will never be enough. We have to see the patient first and then understand how to scientifically heal that person.
Welcome to the second episode of the Humanities podcast by Chest. Our guest today is Dr. Wes Ely, an internist, pulmonologist, and intensivist from Vanderbilt University. Dr. Ely is also an author of the award-winning book, Every Deep Drawn Breath. In this episode, we discuss his Humanities article titled Medicine at its Finest and explore ways to connect to the unique humans receiving your care, navigating your personal biases, refilling your empathy cup, and the role of family in advocacy. Please stick around till the end of the show to hear the author reading their full article in their own voice. Thank you so much. I think this is such a beautiful article, and I want to start by saying that you touch on so many important aspects of medicine. You touch on the experience that most healthcare professionals had during the pandemic. You touch on addiction and how we take care of patients with addiction, sometimes managing our own biases. You talk deeply about the role of family and humanity. And one thing that was very subtle in your article is you said, maybe I should become his makeshift pediatrician. And it's so important to even acknowledge that, because the way we take care of our pediatric population, there's so much to learn from the pediatric ICU team, the neonatal ICU team, and the pediatricians in general, because the kind of kindness that we show to the kid and to their family members, I wish we could do that for our adult patients and their family members. So this is there is a lot we can talk about using this article as our base. But, I know you as a physician scientist, I know you as a writer, an outstanding clinician, and overall a great role model and a human being, because over the years, the interaction I've had, you've always been very gracious with your time. Can you tell me a little bit about where did it all start for you, the kind of person you became, and whether it was your early childhood, formative years, where did you get this level of compassion, and how do you exhibit that empathy through all your work, actually?
Thank you, Abhi, for your question, and thank you for having me on today. First of all, I have a long way to go in growing my compassionate heart and in becoming a better healer. And so by no means do I think that I have achieved any level of acceptable amount of empathy or compassion. What I do know is that I absolutely cherish each moment that I'm with my patients. And when I have the opportunity of finding myself kneeling down at the bedside, and I do get in a kneeling position there every day with my patients, not every interaction, but many, many interactions, it's because my pride is too great and I want to make myself smaller and make them large. And so just physically reducing my height by kneeling, then I put myself at eye level with them. And it's such an easier way for me to communicate and have that eye contact. Where this started for me was back as a kid, back in Louisiana on a farm, working with the pickers, the workers who had so many problems in their life and no safety net whatsoever. And so I began seeing how in my life I had a way out of these problems and they didn't have as many options. And I just became committed one day after another of working with them in the fields, picking our tomatoes and our watermelons and our purple hull peas and all the different vegetables. I became committed to saying I have to serve them. If I've been given more, then I've got to give back. And the way I'm going to give back is through using science in medicine to figure out how to become a healer. And that was what led me to medical school. If I may comment on something you said earlier, when you brought up, Abhi, about this important notion that the idea of being a pediatrician for our adult patients, one of the things that I think about is how each of us has perhaps a best version of ourselves, if you will. And figuring out what that best version is is for each of us to sort out. I mean, I can only work on myself. I can't tell you anything about what the best version of yourself is. But for me, I know that in time, I have, through my own mistakes, gotten at different points further and further off track of what I would think is my best version. And I'd have to kind of come back and, recalibrate my life and what I believe is important and how I'm going to live my life. And I think that whole idea of kids versus adults is that the kid, when we look at a kid, they've had less time to get further off track, and they're more pure and they're more innocent. And I want the heart and the mindset of a child. And in so doing, if I can think of my patient as perhaps not a 60-year-old who's had more and more time to get off track, but maybe think of them as how they were when they were younger, then I can grow in compassion for that person, even in spite of maybe some really perhaps dangerous and or hurtful decisions they made that might have affected their own physical, mental, and spiritual health, if that makes any sense.
It does. And that's such a powerful way of reframing our own opinions. And I truly understand and believe that if we start being kinder to our patients and their families, I think it truly makes a difference in their, not only just how we manage them in the ICU, but also their overall experience. Because, the patients don't expect you to be an extraordinary physician every day, every time, because that's, I think, is already given. They don't expect it from you that you are going to go above and beyond. But to me, that's what going above and beyond means. It's not just putting in the fastest central line, the cleanest way of diagnosing something. Because I think most patients don't know what we are doing for them. That's our responsibility. That's something that is the lowest bar, that being a good clinician, managing those complex diseases as an intensivist, that's the lowest bar. But how we make them feel, how we treat them with kindness, support, empathy, that's what they will remember. Even if the patient cannot remember, the families definitely remember. And sometimes I feel like these are considered soft skills. These are something that some of the physicians are like, what are we talking about? Let's just handle this very sick patients. But, you are explaining the role model way of implementing some of these basic things that should drive us as physicians. And I'll be honest with you too, like the younger version of me will take pride that, oh, wow, I could do the central line. I could put this dialysis catheter chest tube in such small time and finesse. But as we all get older in ICU, I think most of us start to recognize that the procedural part of it is just the procedural part of it. Taking care of the person as a whole is what truly matters. The humanism is what matters in medicine.
Yeah, growing and changing is what I want to do. I don't want to stay the same doctor I was yesterday, much less the one I was 10 years ago. And definitely when I was young, I measured my skill as a physician by how accurately I did put in a central line and or get a lumbar puncture or place a chest tube or intubate a patient. And I think that those are really important skills, and the patients want us to have good skills at those things, obviously. And yet, I had a patient once come back to me years after I'd initially taken care of him. And he had sepsis, and I'd taken care of him in the ICU. And he came back and bounced back to our ICU many years later. And when I was taking care of him, he said, you were my doctor a long time ago. And, this is what I remember about that interaction. And he did not say to me, you did a great job with your antibiotic choices, or you weaned me appropriately off the ventilator. What he said was, one day we were sitting at the bedside and you read a story to me and ripped out of the sheet of the book, a sheet, and gave it to me. And he then went and pulled out of his wallet that sheet. Wow. And he had it all these years later. And it was a crinkled up sheet with this story on it. That's what he remembered. So to me, what I'm looking for here as I grow as a physician and want to be a true healer is, am I making a complete connection with the person who's suffering? And do they know that I am all in about their mind, body, and spiritual suffering, and that I want to be immersed in what's going on with them so that I can be part of their healing process? Not in charge of it, I can't create the healing, but I can accompany them through the healing process. And that is way more determined by our eye contact, our interactions, the words we say to one another, and the questions I ask of them than it is me making my scientific decisions.
That's very well said. And kind of building upon that explanation, this was something that we were robbed of during the pandemic. And this is what you start your article with, that we all were feeling the sense that what was normal for us, what we took for granted, can suddenly be taken away from us in a moment. So the hospital policies, which were in with good intention early on, regarding, okay, we can't have a lot of family members to contain the pandemic. We don't have enough resources, no PPE, so that we can't give those to the patient's family member. But over a period of time, that's what truly caused this sense of void for the family members not at bedside, and that's what you witnessed. And when you saw that families coming back to the ICU, that's what you described, that suddenly you felt like this was the missing piece. And seeing the family members holding hands of their loved ones is what brought joy back to you. Is that a true sense?
Absolutely. You know, the intangibles of healing have much to do with the human connection. And regardless of anybody's spiritual background, cultural background, socioeconomic background, what ties us all together is that we all are human beings at our base core, and lifting people up according to humanism, just the sheer fact that you are a person. You know, right now I'm caring for my brother-in-law, my wife's only sibling. He has Down syndrome. And I told you as we were getting on today, he's suffering right now from acute mania and hyperactive catatonia, which has just been brutal to watch him go through. And his Down syndrome makes it extremely difficult for him to communicate. In many circles, he would be thought of as, I think, less than human, and not as an entire human being, not as an entire person. And there was a famous editorial in the New York Times years ago written by a man with a primary neurodegenerative disease. And he said in this article, it is like a tsunami how society makes me feel like I'm in the way. Like with my primary neurological disease, the more disabled I get, the more I grow my disabilities, the less worthy I am to be present. And what I'm saying here is that whether it be that person who wrote that New York Times article or my brother-in-law, Greg, who is 59 with Down syndrome, what's helping me be a better doctor is to see this entire person, regardless of what disease they have or their physical, mental, cognitive disabilities. Each person is of inestimable value, absolutely priceless. And no amount of disease reduces that value by an iota. And if we walk to the bedside and bring that with us to the bedside, then we don't judge people by any of their external physical attributes at all. We just say, this is an entire person, just like the person in the next bed over. And we say to ourselves, okay, Wes, get rid of your prejudices, kneel down, look at this person, and realize that you have to bring everything you have here to love them in their suffering. And if in the absence of fully loving this person, you are not being a true physician here. And that's where I'm coming from as my starting point. Then I figure out, how do I do that one moment at a time at the bedside?
I love the way you think and how you process this and how you execute this every day in the ICU. And I can see that, many of us who work very long hours and after a long stretch of night shift, I can see that compassion and the empathy, the volume can go down. And it might be a way to pause and reflect after each encounter, the way you're describing that, look, I need to recenter myself and perhaps take a pause before I go into the next room, because my empathy bowl is kind of empty right now. So maybe take a 2 minute or 1 minute pause just to do that.
I'll tell you a great story about that. You want me to tell you a good one? I've never written it down yet, so I'm telling you this live, and I've not written this yet. But I think this is the perfect place to do it. I was about to go into a patient's room, and the residents outside the room told me that we had a new diagnosis of lung cancer with liver metastases. And went in the room to tell the woman this, but she was delirious, and the daughter and the son were there. And over the next 15 minutes, it was excruciatingly painful, the conversation that ensued. And we were at odds of the diagnosis. We were at odds about what to do about that diagnosis. And we had to figure out a way forward as healthcare professionals, physicians, nurses, et cetera, and family members and the patient. And without getting into the details of it, because we don't have time for that right now, eventually my brain was thinking that you might be hit in a minute, like physically you might be hit. And she told me later, yes, she almost did that. But I said, my brain just kept saying, stay, don't leave, just stay, be present, don't go. And eventually my hands were on her shoulders, her hands were on my shoulders, our foreheads were touching, and she was crying, the residents were crying, I had tears in my eyes. It was so intense. And we walked out of the room when all that was said and done, and the residents were crying, several of them. And I looked at them and I said, okay, let's just stop rounds for a minute. Let's unpack this. They said, one of them said, I've never seen all the stages of grief in like 10 minutes all at once like that. And I said to them, look, people ask me if I'm a glass half full or a glass half empty person. I say, I'm neither. I'm refillable. And I said, and right now I am empty. That took everything out of me, that experience that we just went through. And I'm wasted right now. And I said, but later today, I will go for my swim. I swim for an hour and a half, 2 hours. If I can, sometimes it's just 30 minutes, depending on what's going on. I have to meditate, pray, process, refill, whatever the process is that you have, Abhi, or anybody who's listening, please do not undervalue the importance of refilling your cup with whatever mechanism you have determined is appropriate for you. And if you don't have one yet, work hard. I go to Al-Anon, which is for people who have addiction, others who have addicts in their life. I have lots of people who have suffered from addiction in my life, so I go to Al-Anon. And Al-Anon, we say, it works if you work it. And what I'm saying is work to find out how to refill so that you can bring compassion and love. Compassion is compatior, to suffer with. You want to be able to suffer with your patient and their loved ones, but you can't do that if you didn't take time to refill.
Well, thank you so much for sharing that powerful moment and for, again, being a role model, because trainees adapt and will remember this and actually potentially pass it on to the next generation when they are in that moment, because family meetings are part of our everyday life and we are frequently in these moments where we have to truly take a pause before we just move on to the next patient. All right. So I was going to ask you that, you mentioned that the intensive loss of human connection by the policy of disallowing any family or loved ones from visiting patients, it highlights to me the role of family advocacy. Can you elaborate on that? Because I see that all the time, that when I am the intensivist and I have no family members at bedside to talk to, I will round and we will discuss and we will update the family over the phone, and that's the end of it. But anytime there is a family member at bedside, that just changes the way we perform. And it is, at some point, very performative. Because when families ask us questions, they challenge us, and they challenge our own beliefs sometimes, that why are we doing this? It allows us to explain to them. In that process of explaining to the family members, we sometimes register that maybe there is a different way to manage this. And these can be something very simple, like you talk about early mobility here, you talk about delirium precautions, all of that in this article. So I love the idea of family as part of the ICU team. They are truly the part of the ICU team. What is your opinion on this?
You asked me about the importance of family at the bedside, and I want to say that when we first built the ABCDE bundle, it didn't have the F on it. Right. It just was the ABCDEs. And that's, for those listening, that's analgesia, both stopping the ventilator or stopping drugs to allow the patient to wake up and see if they still need the ventilator, choosing drugs to see that aren't, for example, benzodiazepines. D is delirium management, and E is early mobility. So our thought was, let's make sure people aren't in pain. Let's stop the sedation and the ventilator, see if they still require it. Let's avoid dangerous drugs like benzo drips, and then manage their delirium and get them out of bed. Wake people up and get them out of bed. That was the basic concept. And we went to California where the Gordon and Betty Moore Foundation had funded this program. And there was a nurse there, and her name was Jet. And in every deep drawing breath, this book that I wrote during the pandemic, actually, and every penny of this book goes back to patients and families, by the way. I took no money from this book. I wrote the following. We were trying to teach nurses about this idea of family. And so Jet first starts. Jet told me how she approached changing the culture of critical care within the hospital system. Quote, I went to the ICU in my small hospital. I told them, here's the bundle, the A, the B, the C. And I explained everything to the nurses. I said, so this is what we have to do. This is the cool new stuff. They said, great. 2 weeks later, I went back. You know what they had done? Nothing. And so we started, then I'm skipping a little bit in the story, and she went out and got this grant. And why Gordon and Betty Moore? Gordon Moore, the founder of Intel, the billionaire, had been in the ICU, and he had been delirious, and his family was not allowed to visit him. So back to your question, what about family visiting? Gordon Moore didn't have the family there, and he said, this is absolutely wrong. I hated this, and I'm going to fix it. So he sent money to the Society of Critical Care Medicine, which also partnered with CHEST later on to do a better job of incorporating family at the bedside. And so when we pitched the A2E bundle, he said, like the soup Nazi in Seinfeld, no soup for you, and I'm not going to give you any money unless you incorporate family. So we added the F to the A2Es, and it became the A2F bundle. And then Jet comes back and she said, I told them what sedation was doing. I told them what tying patients down in bed was doing, how they couldn't walk or have their jobs or have their spouses and their families at the bedside. How they said that they'd rather be dead. I had nurses crying. They thought that they were doing the right thing, but that's what we've been taught. They said, we didn't know. I said, I didn't know. I'm learning all this stuff too, but we're hurting people. We're breaking their brains. I read that to you because the experience of all of us at the bedside will be better informed if we have the people who know the patient best right there with us. And the basic core structure of the A2F bundle is to have the patients with us on rounds, to have them in the room. Every time I get to the next bed, I say, is there any family members here? If so, either invite them out here if the patient's on contact, or we'll go into the room and we either round with the family out with us, or we go in the room and round at the bedside. That's the only way I know how to round anymore. And if nobody's here, I use the team, we use each other to find the family, to get them there for the next day, because not 98%, not 97%, but 100% of the time, I'm going to miss something if I don't have family members around who can tell me more about their loved ones.
And it's so true, because we see these patients in that moment. This is just a snapshot of their life. We don't understand who they are without the family being an advocate for them and just filling in those gaps in our awareness for this patient. So when the family is there, they tell us, well, mom was actually gardening last week. And then when we see this patient, the elderly 84-year-old in bed, unconscious, we don't understand that this was a very high-level functioning woman last week. And then our biases and prejudice then kick in and like, okay, we do what we need to do. But you bring up this beautiful point that families are not just important for patients, but they're important for us too. And it also brings the other aspect. We humanize the patient because of the family members too, because the way they look at the loved one is how we should also look at them as a person, not just the patient.
You know, a lot of times when we're training as physicians and going through residency and fellowship and so forth, or early as our time as attendings, we all think to ourselves, I don't want to be a good doctor. I want to be a great doctor. I don't want to practice good medicine. I want to practice great medicine. And I would go so far as to say that I cannot be a great physician or practice great medicine without this humanistic side to my science. They go hand in hand. It can't be science. Science will never be enough, Abhi. It absolutely will never be enough. We have to see the patient first and then understand how to scientifically heal that person. And that's, to me, the only approach now. I didn't used to think that way. I think I was essentially either causing harm or necessarily not doing as much good as I could have done when I was a younger, non-gray haired physician and not thinking this way. So I'm very encouraged by the younger physicians now that I get to work with, because they not only are being taught the humanistic side of things, but they're bringing it to the table with great love. And I'm so grateful to be with them at the bedside with their patients and watching how they're caring for their patients' mind, body, and spirit.
I think a lot has to do with the culture that you probably has established in your unit and your colleagues at your institute. And I think what we see as trainees is what we imbibe. We always had our role model physicians, our mentors that we really admired, that look, this is how he's doing it. This is how she did this. I pick up different parts as a trainee from different attendings that I had and made it my own. And that's what we then go to the next institute and then change the culture there. You highlight that in describing the case of Joshua, when you took care of him while he was going through delirium, while he was recovering from his addiction, and you looked at him as a person, you looked at him through the eyes of his mother. When he was extubated, when he was able to express himself, you asked some very pointed and very meaningful question. And in 2 questions, you could identify what you needed to do. You asked him, what matters most to you and what can I do for you? Now, I just realized that it truly takes time to ask this basic question to show that you care. And then that eliminates some of the barriers that patients might have, that nobody cares for me. I have been going through this addiction cycle. I've been going through this in and out of the hospital over and over and over again. I get treated, I leave. I get treated, I leave. This is a recurrent cycle for a lot of these patients. And potentially one of these events, that's where they needed a break. And I think you gave him that break by truly asking what matters most to you and what can I do for you? Can you elaborate more on that?
Yeah, I think I can give the listener a couple of tools by which to do this. In the middle of our busy day, we have to be fast and able to think of things so that we can be efficient. I need some quick ways to think about how to do what you just outlined. And one of the ways is to remember to switch the preposition. So instead of me thinking, what's the matter with someone, I think, what matters to someone? So I have to ask them, what matters to you? And that's that switching that preposition from with to to. What matters to you? And then asking that question, I can learn back. Okay. Now, that could be a very deep question, or it could be kind of a superficial question on purpose. Like at the beginning, I say, well, these are Wes's 4 questions. So I practice asking them, what are your favorite hobbies, pets' names, food, and music? These are 4 ways to quickly get down into somebody's life a little bit. If I know something about their music, Bob Dylan fan, I like Thai food. My dog's name is Bacchus, the god of wine. And my hobbies, I like to rebuild carburetors on old Corvettes. Okay, whatever it is that they like of those 4 things, those are 4 quick questions: pets, hobbies, music, and food, that I can carry with me, quickly draw it out of my RAM, and find out something about them. And that I defy you to treat someone as an inanimate object, a gray zone, dehumanized person, once you know those personal things about them. It makes you think of them as an entire person. And then you can get further down. Like I would say to them, do you have any spiritual values that you want me to know so that I can be a better physician for you? And if they say, I'm an atheist, I don't want to talk about God, say, absolutely. That's why I asked you. I want to respect your spiritual values. But they might say, I'm a Buddhist. I'd like for you to get me a Buddhist monk. Or I'm a Muslim and I want an imam. Whatever it is that they ask, I'm going to tailor my spiritual care to them in accordance with their preferences. And that's part, because I say to them, I'm interested in caring for all of you, not just your pneumonia or not just your pyelonephritis, but all of you as a person, or else I can't get you back to well.
Thank you so much for sharing your deep insight into how you have navigated this and found a way that it works for you and it's effective. Clearly, that your experience over the years when you have used this simple strategy of humanizing the patient by showing them you care about them more than the patient by asking these important questions. Dr. Ely, every time I talk to you, I get inspired, to be honest, because when I was reading this article, I had so many different questions, different ways I wanted to discuss things with you. But I think this particular article is not just medicine at its finest, it's also the humanism at its finest, the way you have described things in the last hour. I want to highlight one other thing, that when we all decide to go into medicine, right, everyone is very optimistic. Everyone has such brilliant, bright ideas that we want to make a huge difference and we want to help people. That's the only drive I think most people have when they go into medicine. And then the residency, the medical school, the fellowship, and the burdens that come with all the other administrative roles take first thing out of us, that's the humanism side. And I think it takes a really long effort and introspection to bring that back. And I wonder why that is the first thing that goes out of the window. It's just because we go from motion to motion, running from patient to patient, going from deadlines to deadlines. And the one thing that mattered most to us early on in our life is the first thing that we lose.
Yeah, I readily admit that I have been victim of this as well. I've had moments of burnout over my career. I'm 60 years old now. I've been doing this for 30 years. I absolutely love. Actually, I graduated medical school at 25, so 35 years. I absolutely love now admitting that I need help, and that if left to my own devices, I will leave the present moment and go into the past or the future all too often. And something you brought up with the last question was this idea that I'd written about in the paper about staying in the present moment and holding on to that present moment. And I think this is the answer to the question you're asking now, which is we tend to lose that compassion, that sense of hope, that sense of I'm here to help when we think about our deadlines, our career aspirations, where we have to go with things in the future. And you see what's going on there is I've left the present. My mind is now in the future. I'm trying to check boxes to get somewhere in the future. And if you listen to any of the mystics or read any of the mystics about the path towards truth, the mystics always say the same thing about time. They point out that we don't have any control over the past and it's over and it's actually done. And that the same is true that we have no control over the future. We can plan for the future. We can make our goals toward the future. But the only thing we have access to is actually the present moment. So as a physician with my patients, I try to draw myself back into the present moment as much as I can. And the way that I do that is just say to myself, Wes, you aren't strong enough to affect the past or the future. You don't have the capacity to do that. But you can do something about where you are right now with this human being who's sitting right in front of you. And so I try to make that my way forward is that it's present. There's a famous prayer called the Serenity Prayer. And whether you believe in God or not, it says, God, grant me the serenity to accept the things I cannot change. Well, that's past and future. I cannot change the past and future or other people. But the courage to change the things I can really brings me down to me and the present moment. That's it. That's the whole list. Me in the present moment. So that's how I try and do it, Abhi, is to focus on how can I be a better person at the bedside. And that means working on myself and realizing I have no control over others. And in that present moment is where I need to spend my time.
I love it. And I do want to truly acknowledge that your contribution to the field of medicine, the scientific community, and most importantly, now the contribution to the humanism aspect of medicine is truly, truly great.
I take no attribution, Abhi. I put that all with my higher power, God, and people around me who help me. And I appreciate you creating this space for us to talk about these things that matter. And just allowing me to be here present with you today is such an honor and a gift. And I'm extremely grateful.
And now to our audience, thank you for listening. To close out the show, here's Dr. Ely reading the entirety of his Humanities article entitled Medicine at its Finest.
A seasoned nurse practitioner in faded blue scrubs was standing near the corner of our ICU. Behind her, the morning sun seeped in through the windows of a patient's room. and I watched as her cheeks puffed out into what seemed like a long-awaited exhale. We have been suffering from a long, pandemic-induced pathologic inhalation, and it is never healthy when inhalation isn't balanced with exhalation. 18 months into COVID-19, I was walking through the large unit at Vanderbilt Hospital that had once been our medical center's ground zero. As the numbers steadily rose, this physical space was the scene of intensive caring. At times, our intended benevolence was marred by an equally intensive loss of human connection, wrought by our hospital policy of disallowing any family or loved ones from visiting patients. On this day, though, the unit felt altogether different, at peace. Yet I couldn't put my finger on it. Lisa looked up at me and explained, "This is how medicine is supposed to be, at its finest." Inside Mrs. Snyder's room, I could see family members holding her hands. Miss Snyder's interprofessional ICU team encircled the rest of her bed, and together they were all discussing the plan for her care that day. Before COVID, scenes like this were commonplace and seemed ordinary. Now I'm able to cherish them for what they are, extraordinary in so many ways. Still, for the next few days, I pondered what made it so special. What exactly was it that it made Lisa and me feel so different that morning in the unit? A few days earlier, I was caring for Joshua, a man in his 30s who had been admitted with alcoholic hepatitis. I looked at his leathery, jaundiced skin and saw a person who appeared to be in his 60s. Gin-soaked, I imagined him drowning in grief, aged by fear and desperation. On rounds, our team discussed the right decisions to manage his anemia, delirium tremens, pneumonia, and kidney failure. Every day, his devoted mother, Sally, held his hand, desperately wishing for his recovery, while at the same time recounting for us his incessant refusal to be helped. Joshua, Sally, and I were gazing at the quagmire of his life from disturbingly different vantage points, and this was splintering our vision and our goals. She and I were both in fix-it mode, but neither of us really knew what he wanted. As Joshua drifted in and out of delirium, I learned more about him through Sally. I asked her to bring me pictures of him as a boy. Once looking at them with her, Sally told me who she saw. Josh was a good boy with a golden heart. He had always had so much hope. Behind this horrible disease, I still see him that way, as my innocent boy. The pain for me is that his addiction is too strong. He has never willingly gone into a rehabilitation program and has never practiced recovery. Doctor, I know it's got to be his decision. I just hope he lives long enough to get there, because the most important thing in his life is his daughter, Arabella. She's the main thing that matters to him. From that moment on, I took on the persona of Joshua's makeshift pediatrician. I felt compelled to maintain his mother's vision of him as a blameless boy, perhaps to avoid dispersion of any unconscious judgment toward him. I felt that I was the physician for a severely ill and petrified adolescent, dressed in an old man's body. Sally persisted with undiminished yet weathered love, her heart seemingly protected by its own faded blue scrubs. I held Joshua's hand, tested his brain, and listened to his heart and lungs. I saw a mysterious longing in his eyes. One morning, his delirium cleared. I could see it, and Sally could too. Our vantage points all converged. The ICU team got Joshua out of bed and walked him with the ventilator trailing. Later that morning, we removed his breathing tube, and I came back to his bed to connect with him. Kneeling beside Joshua, I asked him 2 questions. What matters most to you? What can I do for you? At first, I wasn't sure he processed because he stared right past me. The whites of his deep-set eyes were fluorescent yellow and had been swollen. Softly and slowly, he looked straight at me and said, "Any day I spend with Mom or Arabella is what matters to me. How can I stop drinking, Doc? I need help." There it was, the long-awaited answer. When Sally heard, she lowered her head and cried. I looked back at Joshua and nodded. Recovery was now possible. And this had all unfolded at his bedside, together with the family and medical team playing their pivotal roles. The process of healing, even when cure is not possible, must be lived one day at a time and parsed out one moment at a time. Joshua revealed to me later that the villainous voices of his addiction told him that asking for help was weak. In truth, of course, it's the exact opposite. Medicine at its finest is not about correctly titrating medications or acing a spinal tap. It's not only about dialing in the right size breaths, adjusting the dialysis bath, or running safety checks on an extracorporeal membrane oxygenation circuit. It is also about seeing the person in the gown and knowing him for who he truly is. Despite jaundice, bruising, resistant pathogens growing in his bloodstream, or his body's inability to get oxygen across a membrane. What I learned from Joshua was that I became better as a healer if I saw him as Sally saw him. If I tuned his care so that I was serving him, all of him, and specifically him with each decision on that one day. For Joshua, that meant getting him into contact with the people who showered him with the most love. These are the people who draw him forward from one second to the next and help him remember his why to live. Joshua's path to a future day with Arabella or Sally could only be paved through the present. The best prescription included ample eye contact, human touch, and mobility. I watched closely as Joshua began to balance a decades-long desperate inhalation with his long-awaited exhalation. Moment by moment, the elements of a young boy's late life redemption came into focus for Joshua, Sally, and me. Throughout the pandemic, something went missing. For too long, Lisa and all our colleagues felt like we were gasping for air and afraid to breathe out. I lost sight of what grounds me in medicine, but it's coming back into focus. Whether in ICU rooms, wards, clinics, nursing homes, or even home visits, my bearings come from finding the person in the patient who needs me to see her, just her, and for us to work together with those she loves to achieve healing for even the most complicated injuries. Lisa thinks it is coming back, and I do too.